think we're starting to evolve into the realm of how we're treating these patients with various different therapies. So why don't we focus on that now for the next part of our segment here, and maybe starting with patients who have early stage disease and are surgical candidates. Rod, what are the various surgical approaches that are taken for these patients depending on the primary site? Can you give us a little overview?
Yes, it varies greatly on the primary site. So if we start, for example, with the lung carcinoids, we will treat those with standard oncologic operations that we would for a lung cancer, a non-small cell lung cancer in the same location. So a lobectomy, possibly a pneumonectomy with the appropriate lymph node dissection. The great joy that I have in operating on the NET patients compared to patients with non-small cell lung cancer is that these diseases are not associated with smoking. And so one of the great ironies of patients with non-small cell lung cancer is that the patients who most need lung surgery are the patients who can least withstand it because they all have COPD. So most of these patients have normal lung function that will not preclude such a resection. They can also have a syndrome. They're not as common with the foregut tumors as they are with the midgut tumors, but this is one of the circumstances in which a patient can have flushing and diarrhea or even an unusual syndrome like Cushing's syndrome just from the primary tumor draining the hormones back to the heart without them being cleared by the liver. So besides getting a complete resection of the tumor, the syndrome is gone at the end of the operation, which is very, very gratifying. For the pancreatic nets, I divide those into two groups. We have the very small functional tumors like the gastrinomas and the insulinomas, and very often they are not localized by the time the patient comes to me. And the final localizing test is an operation. So they still go to the operating room, but that's where the diagnostic workup has been critical. Because if I'm in there and I'm having trouble finding a primary tumor, I need to know for sure, is it because I haven't looked in all the right places yet? Or is it that the patient doesn't even have the disease? Is this a factitious insulin injector? Or do they have other reasons for hypoglycemia? Or is their gastrin elevated because someone forgot that they were taking a proton pump inhibitor? So I really need to know those things. And the little tumors, once we find them, we can generally enucleate them out of the pancreas without a major pancreatic resection, provided it's not close to a big duct. The larger tumors, like the vipomas and the glucagonomas, the operation will depend on where it is located. If they're to the left of the mesenteric vessels, we will do a distal pancreatectomy and often a splenectomy because it will involve the splenic vessels. But if it doesn't, we'll try to spare the spleen. And if it's to the right, well, then it will take a Whipple resection. For the small bowel tumors, again, as I said, when we see patients with large mesenteric nodal masses, the primary tumor may be very small. So even if we have a patient with just a small mass, we have to impute that there may be nodal metastases. So we'll do a very wide lymph node resection. Generally, it's a glorified right hemicolectomy with all the nodes being taken flush with the mesenteric vessels right up to the root of the mesentery.
You know, you'll sometimes see patients coming in where the surgeon has been surprised and they find a carcinoid in the small intestine and they just do a little wedge resection there. Do those patients need to go back for a bigger surgery?
Yes, they all need to go back for the wider resection that I just described.
You mentioned, though, for some of the smaller pancreatic neuroendocrine tumors, one doesn't necessarily need to do a big wide lymphadenectomy. Is that the case?
Well, no. For gastrinomas, we will do a lymphadenectomy because about 60% of patients do have lymph node metastases at the time of diagnosis. So we'll do a periportal, periduodenal, and subpyloric lymph node dissection with that. With the insulinomas, as James already alluded, they're almost always benign, and we do not see. So unless we see nodal disease while we're there, we will not.
So the decision depends not just on the tumor diameter, but on the clinical presentation and what specific subset of pancreatic neuroendocrine tumor it is.
Correct.
So another topic that comes up with surgery in neuroendocrine tumors. It's not uncommon in these patients to consider surgery even when they have metastatic disease. So is hepatic resection or resection of metastasis for stage 4 disease something that you'd recommend?
Yes. This is an area where the outcomes for patients with neuroendocrine tumors are very different than, say, for colorectal cancer and primary hepatic tumors. There are very strict criteria about who may and may not have liver surgery for, say, colorectal metastases, and that we can't have extrahepatic disease. The primary tumor has to be out and controlled. And there has to be some type of resection we can do where we will leave behind a liver remnant that is completely free of disease. And even if we think we did that, the pathologist is going to check the margins, and if they see disease at the margin, well, then that's going to lead to recurrence, and it's going to be considered fairly futile. And none of those rules really apply to neuroendocrine tumor patients. Several series have shown that patients who can have 70 to 90% of their disease debulked will have the same outcomes as patients who have a 100% resection. And the survival for patients with incomplete resection of liver disease is superior at 5 and 10 years to patients who have complete resections for colorectal metastases. The other thing is that, after a resection for colorectal metastases, patients don't really feel a lot better. I mean, we impact their survival. But if a neuroendocrine tumor patient has functional syndrome, they get a marked improvement in that syndrome after the operation. Their functional status goes up. It's quite durable. It's about 65% of patients still have symptomatic improvement at 5 years. And margins don't matter so much. With colorectal cancers, they land in the liver and they invade out with tentacles, which is why we need the wide margins. Neuroendocrine tumors land in the liver and they push. And what you see is what you get. So we can literally enucleate these tumors. And when we follow them on CT scans, we look at the cavities of where they were. We do not see recurrences there. Rather, we're more likely to see a new tumor show up somewhere else. So the margins don't really matter.
So in your view, this might be a little bit controversial, that debulking may very well be beneficial. You don't necessarily have to get the negative margins. So let me push on that a little bit and turn to James. You're at a major cancer center. Do you have the same view, or would you treat someone with multiple hepatic metastasis in a somewhat different way?
Well, I think we evaluate these cases individually. I think it's definitely true that, as Rob mentioned, many of these patients who can undergo resection do quite well. The open question is whether we have selected for the better biology for surgery, or is the surgery bringing a major benefit. I think the sense is for many of these patients there is a major benefit, especially if there are symptomatic improvement and so forth. These are slow-growing tumors, so you're setting the clock back. But I would advocate that before doing so, these cases should be discussed in a multidisciplinary conference. Often it's the patient who have the more indolent course that benefit from surgery for a longer duration of time.
Pam, do you have a fixed set of rules at your center for who should undergo hepatic resection and who should undergo other treatments?
I think it's very similar to what's been said. I think that we do try to discuss these patients in a multidisciplinary context, and it's individualized. I think to make one other comment is, can we help improve their survival or reduce the risk of recurrence in any other way following a resection? And just to make a comment is that we have a cooperative group study that's coming up that's going to try to answer that question for pancreatic neuroendocrine tumors through ECOG, that will take patients after an R0 or R1 resection who have metastatic disease and then randomize them to either receive everolimus versus placebo. So a la the GI stromal tumor world of really trying to see if we can push that a little bit. So to be determined.